Welcome to Connected by Health. I'm Dr. Krishna Madala. This is where medicine meets leadership, innovation, and humanity with one goal: to add value and help change healthcare for the better. If you believe health is about more than a diagnosis, you're in the right place.
All right. Today, we have someone that I'm really excited to have on. Today's guest is someone who sits at the center of patient care, but is often overlooked when it comes to the big healthcare conversations. Brant Alexander is a licensed pharmacist with nearly 20 years of experience, who is the CEO of Sooner Pharmacy and Compassionate Care Pharmacy. He brings a very unique perspective on medications, patient safety, and also about how the healthcare system really works on the ground. And so I'm really excited to have him here to share insights that every patient and clinician should hear. So, Brant, thank you so much. Why don't you tell us a little bit about yourself and how you got into pharmacy?
Sure. Thank you for having me. Yeah. So I kind of started the career path of pharmacy at a young age. It was probably about 16 years old or so. My father was a sales rep for company Morrison Dixon, who is an independent wholesaler for independent pharmacies. And my very first job was kind of traveling around with him to these independent pharmacies throughout the state of Oklahoma, and just I loved medicine. I loved chemistry and all that. And then coupled with the pharmacists there were just such a community. They were just part of the community that, you would come in and everybody, you knew everybody's other names and their kids' names, and they just felt like this big local family. And I thought that was just really cool and just really appealed to me. So that's kind of how I got ventured into it. And then after school, I went to OU and graduated in 2006, and that's where we're at. So.
All right, Boomer Sooner. All right. One of the things that I kind of see as a primary care physician every day, and even when I was in medical school, and even before then when I was a patient myself, is prescriptions. And they tend to play a huge role in not just in how patients are taken care of, but also just in kind of our daily lives. And so what are some of the main drivers of high prescription drug prices in the United States, and what factors do pharmacists see most directly in practice?
Sure. Great question. So in the United States, we developed a entity called the Pharmacy Benefits Manager, which is the PBM. And this entity works with the insurance plans, and it's kind of the middleman between insurance plans and the manufacturers. And their role is supposed to be to help reduce cost of medications, but that has been tainted and lots of complications through many reasons, some just transparency and whatnot. And ultimately, there's no incentivized to uncouple them from raising prices because they make more money. And so a lot of prices are very inflated, and we use some outdated business models for how we come up with the price, like AWP and WAC and things like that. And so those things are kind of artificially increasing the price and not benefiting the patient or the consumer.
Um, one of the things I've noticed over the course of my travels across the world, whether that is Mexico, most European countries, or even India, I've noticed that the United States is so unique in the sense that the majority of the prescriptions usually need a prescription from a provider. Whereas when I travel outside of the United States, and at least in my travels, I've noticed that they don't necessarily need a prescription. I found azithromycin and amoxicillin over the counter in India. My brother was telling me the other day how he found, I think it was another pretty strong antibiotic, if I'm not mistaken, macrobid, and I think some other medications just over the counter in Europe. Why is the United States so particularly restrictive when it comes to prescription services compared to other places?
Yeah, I mean that's a probably a complex question and a good one. I agree. My family and we pride ourselves in being worldly, and we take the kids. They've been to Mexico, and they've been to nearly every state or every country in Europe, and we've seen the same thing: UK, Mexico, and several others. I think the sweet spot is more of relaxing a little bit of what we do here and implementing some of they do there. But I have some concerns about antibiotics and things like that. I think that what makes a ton of sense to me is that we really need to get pharmacists to be able to be defined as a provider, having some sort of provider status. Should it be on the same level as a nurse practitioner or PA? Probably not, because we need to focus on what we do. But what makes the most sense to me is have a unique carve out of some particular antibiotics and a few different things that would allow us to have that tool in the toolkit to where a patient could do consultation and we could prescribe them. And then it at least allows you to not be having somebody just constantly buying antibiotics, and antibiotic resistance is a big concern, and so I'd rather have the ability to have a trusted patient coming into me with that easy access to the healthcare without having to even being able to charge them a lower service fee because we have multiple revenue streams coming in, and then at least then protecting that and not causing harm by somebody taking too much of a particular prescription medicine that's converted. So I do think that that is a great thing they do in some degree, but I also think it just needs a little bit more oversight to protect the patient.
Got it. How do pharmacy benefit managers, or PBMs, how do they affect this drug pricing and patient access? And what reforms do you think would most improve transparency and fairness?
Sure. So the biggest drivers of the increased pricing and drug pricing set in general are just so when the PBM, the first thing they do is when a manufacturer gets a drug on the market, they've got part of their battle done. They passed all the regulations to make it that it's safe and effective and all those good things. And then if they can't get, they're basically their gatekeeper market shares, PBM. They have to negotiate with them and say, it's a great drug, congratulations, but you have to give me this X amount or you're not going to get into the market, because everything is driven by the insurance industry in this country for the most part, especially on the brand name side. So what they do is they have the kind of a negotiated reduction in the rebate that comes from the manufacturer, but they don't pass that through to the patient. And that's one of the major problems with this industry is there's no incentive for them to lower the price. If they lower the price, they make less money. And frankly, we really need to revamp the system, whether we abolish PBMs, which there's good arguments for that in my opinion, or if we don't, we need to restructure the regulation on them to where they can get paid in different ways to where they're not having this direct impact on not allowing the manufacturer to pass that cost on to the patient, which is essentially kind of what's done in all the other countries that have a single payer system. So that's one of the things they do. There's many others that are problematic too. So with that coupled, you have far majority of health plans are moving towards a high deductible health plan. And if you have a high deductible health plan, the insurance company is supposed to negotiate your price down, but on brand names, they really don't do much of any, and they really don't help a lot on the generic side either. In fact, they're often both are inflated. So that's problematic as well. Really, the only negotiator of price to some degree that has more grit to it is Medicare. So there's pretty good arguments for Medicare for all. It would be a long conversation, but there's some benefits that I could see for the overall U.S. And then some of the other things they do that really aren't essentially almost illegal in every other industry that they can steer the patient to their particular mail service by quote unquote forcing them, or they don't want to call it forcing them, but they can literally pay a higher copay if they work with their local pharmacy versus what they pay to the mail service company. And most of the time, the PBM owns the mail service company, so you've got conflict of interest there as well. And that's one of a couple different laws that we passed in the state of Oklahoma. And we were the first state in the nation to implement that. And that's a great thing. But the problem they're also having with it is we're having difficulty enforcing the law. They're just brazen and they do it. I figure that it almost seems as if they're piling some money to put towards their lawyer and load up. And then when they get sued, they're still making money anyway. And that's kind of what it feels like. And our attorney general has done a great job. I'm very impressed with him. He has been very tough on the PBMs, and we've had a lawsuit settlement from CVS Caremark that's been beneficial and whatnot. But ultimately, that's one. And then you have the concept of spread pricing, and that's just where the patient will get they'll get one of their, what's the word I'm looking for, not invoice, but their what do you call it, the explanation of benefits. And sometimes those will list the pharmacy, and it will show that when, let's say I bill a medication for trying to think of a newer one that went generic, like a generic Entresto is a great example because that just came out. And it might showing us, getting paid from the PBM $50, and on their explanation of benefits, it'll show like $150. And so, and then they're pocketing that money. We don't get it. So they spread price them, and they're getting the difference between what we get paid and what the insurance plan is paying them, which just further increases the price. And Honestly, I think that the insurance companies do it because then they can justify their higher premiums. So they're like, and it's the same as the hospital. You can pay $500 for a Tylenol tablet and all that crazy stuff. A lot of them are happy to pay it because then it further justifies well, this is why we have to have our premium so high, So that's a pretty broken system that just has to be fixed. And again, this is another one that was partly in our law, but it's just we're having a lot of times of getting them to enforce it. So.
Now, Mark Cuban, he came up with, I think it's called, and please correct me, is it cost plus drugs? Is that
Yep.
what it was called?
Yeah, exactly. Yeah.
And that is eliminating these PBMs, correct?
Essentially, yes. Yeah. What he's doing is he's taking his capital and publicity and known and all his network connections and putting out a system that was honestly already kind of there. A lot of independent pharmacies are doing it, and some smaller guys were doing it. So I'm not going to say I wouldn't completely give him credit for that, but I am thankful that he is a big name and a big player and a billionaire and all that, and can make that scale larger. So yeah, a lot of the ways he's doing things are really good things. I mean, I've watched a few podcasts on him, and he's a smart guy. He has really great doctors on his team, and
Yeah.
they are doing good things for sure. The most difficult part is still related to some of the brand names, but what he's trying to do is go directly to the manufacturers, and I think he's going to go even to having his own wholesaler or supply area that he can do these negotiations and get them straight there, and then he can go with this pass-through model. I think that's very slow because there's a lot of brand names out there, and it probably takes an enormous amount of time to get those. But I think he's rolling out more and more of the brand, which is all of them important, but the brand name drugs are the ones that are have the biggest impact on cost.
Well, it is something that is just heartbreaking to hear, just how patients are not able to afford medications, and a lot of it does have to do with the increased prices that here in America that we have to pay, specifically thanks to PBMs. But speaking of that, what role do you think pharmacists can play in negotiating costs, promoting generics and biosimilars, and reducing the out-of-pocket spending for patients?
Sure. Just to be a little bit personal to harp on the thing you had mentioned, my youngest son has type 1 diabetes. He developed type 1 diabetes at 18 months or 16 months old. So, which is uncommon, as you know, but the whole insulin debate over the last few years has been really, really a good thing because at least kind of got the conversation initiated. It's really one of the first drugs that we actually were able to get the manufacturers and the PBMs on board with lowering the price. And it's just a tragedy, man. Some people can't afford me because often if you're in a high deductible health plan, you're going to pay $500-600+ for potentially, depending upon your insulin demand, 30-day supply, maybe even 15-day supply. And that's just not affordable for a lot of people. But so I'm optimistic. I've seen some stuff of what like kind of grassroots and putting pressure on politicians and all these systems to do this. So we've seen some of this. We just need more of that. So I do agree with you totally. I've firsthand experience to the difficulty of that, and obviously I have many stories of patients in the pharmacy that are just hard to hear. But to answer your question, I mean, there's really we need a few things, and one of them is having the ability to have kind of a type of super PAC type system to where we have all these independent entities in the healthcare that are there for legislation, but there really is no coalition amongst healthcare teams. And this is something I've thought about a long time, that most of what aligns with my values aligns with doctors' values, aligns with PAs, nurse practitioners, and we all just want to be able to take care of patients in an efficient manner at the most cost-effective way, And so in a lot of ways, we align a lot, but we're always going to the Capitol and kind of doing things independently of each other. And we'd be much more powerful if we could get together and somebody could kind of be able to steer that, because I think that would have a much bigger impact, because then they've got, several aspects of the healthcare team, joining in the fight. So that's one thing that on a very practical level, I think could be super helpful. And then if we're going to keep PBMs, because I'm not sure that there will be a political will to move them, we just have to renegotiate and structure the profit business model that they have. One of the easier ways is just to get rid of that non-pass through through the manufacturer and more towards something like and part of the new law came out that does a little bit of this. So I do commend legislation, president, all that for looking at it. But basically, if we're going to keep the PBMs, we need to move to a kind of CMS negotiated price with transparency and auditing to ensure that the money's passing through appropriately. But they'll also give them some kind of service fee of some sort to help keep them around if that's what we decide to do. And then we can have the plan has their portion that they pay towards it, and then also the patient has their portion. So if you have 3 different streams that are bringing in a fair price, they should have enough revenue to keep themselves around. Will their profit margins fall? Yes, but do they need to? 100%, because they're not putting out enough value in service to justify the revenue that they're seeing, and we all know that it's just not talked enough about. And then really just those would be some of the best anchors for it to kind of overhaul that part of the system.
I really like your idea of people from different aspects of healthcare coming together. And you're right, we all have the same values. We all want to do ultimately what's right for the patient. We want to make things affordable. And then I really like that idea. And maybe you and I should really, at some point, sit down and talk more about what we could do about coming up with a pack like that. Definitely. And you kind of touched, a little bit on this about CMS. But when you're looking at CMS, and how would Medicare negotiation of drug prices or allowing importation from Canada impact pharmacies and patients, and of course also manufacturer incentives?
Well, ultimately, we have to be sure that CMS is transparent and can be trusted, because they are a critical piece in this. So they need to have transparency in their own of some sort. If nothing else, it would be great if you had some kind of portal as a patient that you could log into that would show more transparently who is paying the PBM what. Probably won't happen, but we have to get to where there's public trust in CMS more public than there is now, so that they can help with that negotiation, because they're really the only entity that makes a lot of sense to be able to do that. Because if you bring in another private sector company, we're likely to run into the same issues that we're already dealing with. So I think that's kind of part of it. And then, and again, we do have that new law that came out with maximum fair pricing, which is allowing select drugs to have some of the WAC reductions, which is part of the model they use to bill a claim and get paid, and what the cost comes in. And that needs some revamping too, because it is inflated like AWP. And then really to push to having the manufacturer more intimately involved in reducing the price, because they can't really reduce the price as much as they want, because these deductions are just going back to, again, that. And again, to me, I think that it makes a lot of sense to still entertain the idea of Medicare for all. It can certainly still be all private sector. You just have the government as the payer. And then we'd be moving more towards some of the European style that have greatly reduced. I mean, some of their branding prices are less than a third, sometimes a quarter of what we pay. And it's because we don't have a negotiation power. We have all these people that are independent, quote unquote, negotiators, and they don't really have any power, and they don't control the system. The levers are all pulled by the PBMs. So I still think we can have private sector and all the healthcare aspects to the most degree, which I think is a good thing. But I think we have to restructure how these companies are getting paid.
You're right, because I was hearing reports about how in some Asian countries you could get Manjaro for $50, the starting, and I'm just like, wow, that is just incredible how cheap it is. It's found those kind of medicines are found outside of the United States, but here we're paying at least 500 or 1,000. And so you're right. We in the United States, we the general population, we really don't have that negotiating power, and it's sad. It really is.
Sure. And then
One of
one rule to harp
Right.
on is that this new legislation that came out is allowing us to get some of that reimbursement back to the pharmacy, which is great. This is going to help not kill independent pharmacy. There's more independent pharmacies going under than ever before, and it's a big problem, especially in the rural areas. And then you've got really healthcare restrictions that don't provide good care if you don't have pharmacies there too, because they're kind of middlemen between a lot of the systems and whatnot. But the new system, the main kind of issues I'm seeing right at the gate is that this manufacturer reimbursement, basically we're getting paid around like 75% from the PBM and the plan or whatever, and then the other 25% is coming for the manufacturer, with the idea of preventing us from dispensing medication that we're losing money on, which is insane because most industries never work that way. But in an independent pharmacy, every day fills medications that they lose money on. And I mean, I literally have patients where I can look at their profile, and if I take their total drug spend, what it costs me to provide medication to them, often I can see somebody that spends $3,000 a month. So I have to pay $3,000 to keep their meds to dispense to them, and I might make $20 if I'm lucky. No business in the world would take that kind of negotiation. I mean,
Mhm.
that's the and I'm not even trying to be greedy. I just want a decent return on investment that's fair, but we do for every business sector, but that's been a major problem. But with this new one, I have seen a trend that it is helping independent. We're not making much more. Sometimes just a flat out loss goes to a net zero, but that's still in the right direction. And again, I don't think making an exorbitant amount of money is the idea at all. It's just more consistent payment. So if you gather new patients, you can have a more predictable know of what kind of patient you're working with. Especially because as a business owner, the thing that's so egregious in a lot of ways with the PDMs and insurance industry is
Mhm.
it almost makes you feel like everything is a commodity. And as a business owner, even the patient's a commodity. And I'm like, well, I don't want to take this patient on because they might have $3,000 drug spend and I might make $10. And that's just not sustainable. And that's not a good way to look at it. And it's human nature to want to look that way because you're a business owner, you got to survive, but we have to get away from it. It has to be more predictable. If I could
Mhm.
say I'm picking up 100 patients, I can know that on average, I'm going to make this much per script and make sure that there's even enough there to be able to operate with that increased growth.
No, no, definitely. And you may not know the answer to this question, but as we were talking, I just thought of another one, which with the Trump RX pricing and in the negotiation, is that mostly done behind the scenes where the government is paying Novo Nordisk and Eli Lilly a certain amount of money? Or is that's done, because you mentioned transparency, that all open and transparent?
Yeah, that's a great question. I'll be honest with you, I don't really know yet because
Mm.
I think the president's idea is, I mean, honestly, I just don't think it's deeply thought through, and I'm not completely convinced, at least any time in the near future, that it'll be implemented because there's still a lot of things to work out. I believe. I do believe the intention is good, but I don't think the president has a deep understanding outside of healthcare, and they have to deal with a lot of issues. So it's not necessarily meant to be, a knock on the president per se, but they have to deal with so many issues, and healthcare is incredibly complex. So
Hmm.
I just think there hasn't been enough thorough evaluation of it. And same kind of goes with ACA. It had a lot of good things in it, I believe, but it's so complex that there's definitely some issues within that system that
Yeah.
are there are just so many different conflicts of interest and entities involved, and all over there. So I'm still not convinced that that's going to roll out and be super successful, at least in the immediate future, because there's going to
Mhm.
be this kind of stuff going on. But I hope for the best on it, of course.
Yeah. And then I agree too. I do agree that both the ACA and the Trump RX, I think the intentions are both really good. It's just, it's such a complex system out there. I don't really think that the ACA worked out the way that it was initially envisioned. And I don't really know how the Trump RX is going to work. And like you said, if it's ever going to roll out. But speaking of reform, what are some pros and cons of side of care and reimbursement reforms, such as separating drug reimbursement from dispensing fees or changing the 340B rules?
Sure. So I think in a very practical way, kind of getting a more larger scale of a Mark Cuban cost plus is a great idea. It's a very transparent model. It's very predictable for the pharmacy. We would be even willing to take a less reimbursement if it's consistent. That's the key term because then we can build our kind of business model around something we know that could work. But there's so much ambiguity and unknown factors that can come in, and you can literally have a brand name drug that you lose $40 on, and then the next patient walks in with an insurance plan that you make $10 or more, and you can see almost $100 spread between different insurance plans on what you're going to get paid. And so that just doesn't work for any business owner. That's why every other industry for the most part is able to kind of to some degree set their own price, and they do it based on market forces and what they need to stay in business and whatnot. So going that model could be extremely helpful for the patient and the pharmacy and for transparency for the providers. I mean, we worked really hard at Senior Pharmacy in making a kind of a cost plus model like they have on our program called Sooner Saver. And you can literally go in there and search alphabetically for the drug. You can see it and it'll show you the price. And we show the model is the price is basically close to what they call NADAC, which is a good model. NADAC is data that is CMS receives from independent pharmacies throughout the country, and it's actually what a lot of the Medicaid is paid on. So essentially, if you can make a NADAC and then the pharmacy saying, this is what I need just to cover my cost for the drug. And then after that, you have a service fee that would be basically allowing us to do what we need to do, and that is shift from just a dispensing kind of commodity look on how we get paid to providing higher levels of service and getting paid for those services. So that's kind of one thing that I think could be really helpful. It would, lower cost, more transparency, and better patient outcome if we can negotiate that service fee to a level that can allow us to do that.
Mhm.
Um, as far as 340B, I think the biggest problem with it is again, there's not a ton of transparency in it, and it kind of flips it on its head. You've got some of these bigger pharmacies that are out most of the time are corporate, and they can get this government contract pricing, and this just goes back to a single payer. I mean, 340B drugs can be crazy. I mean, you could have let's just take Mounjaro. It's $1,000 on a 340B. It might be $20, literally. It's
Mhm.
insane. So that just tells you right there, the manufacturer, our price is grossly inflated because they're not going to sell something to the government that either is too low. They're either not making any money or below cost, which they're not going to do, or they're getting a pretty heavy kickback from the government to it. But what happens is most of these are kind of contracts that are negotiated with hospital systems and sometimes independent practices and whatnot. But if they can charge a fee, physicians aren't really astute a lot on prices because you guys have to deal with plenty of other things, and they can get ripped off too. The pharmacy then can spread price to them. And on the bigger systems, that tends to be happening too. So it's kind of the inversion of the other. So
Mhm.
that's my understanding. I don't have any 340B accounts, and they're not all bad. It's just there's some bad actors out there sometimes that are causing
Yeah.
that.
And just real quick, so to our audience who are not from the healthcare industry, would you be able to just kind of summarize what 340B pricing and 340B is?
So 340B is if the pharmacy they use their primary wholesaler, which they buy their medications from, they literally have the ability to, if they set up a contract with an entity, a lot of I'm trying to think of a good example, I think it's Variety Care is one
Mhm.
that's in Oklahoma that services low income populations, and it allows kind of more access because they have the ability to most of them are on Medicaid, but if they're not, or they have a drug that's not like on the formula or something, sometimes they can utilize this aspect. And so what the pharmacy does is they'll literally carve out two separate accounts. They'll have their traditional account that they buy medications from, and then they'll have a 340B account, and it's all coming from the same wholesaler. And they can literally order, we'll just stick with the GLPs, like a Mounjaro on the traditional side, the cost will come in around like $950 or something along those lines. And then the same drug might come in that very same day on a different account, then it may be $50 or something. So it's pretty wild. But then again, it's really all about that contract. I mean, I think it can work if there's good, solid contracts written, and physicians and those entities know how to have a good negotiation, because the pharmacy basically kind of gets paid sort of like a fee in the insurance company, but they can grossly overinflate what the cost is because there's a huge gap there in price,
Mhm.
and make more than they really should be making.
So now, my experience, and please correct me, it does seem like it's some of the federally qualified health facilities such as Variety Care or the health systems, specifically community health systems like in the rural area hospitals. Those are the ones that tend to be 340B pharmacies. But I haven't really noticed that with some of the bigger corporate ones like a CVS or Walgreens. Is that correct, or could they also do 340B pricing?
To my knowledge and understanding, that's correct. I'm not aware. I have managed a few different CVSs, and when I was there, we never had any 340B in them. So personally, I haven't seen it and I haven't heard it. I think that potentially it might be because qualifying for that is a little strict,
Sure.
I think it should be to some degree. When we won't have access, but we also don't want to build a more corrupt system and whatnot. I think there's some qualifiers to that too. It has to be sometimes rural is one of the points that get you in there. It might be what is your overall community's kind of average income and whatnot, and you have poor areas, they can kind of qualify. So I think there's several factors that are involved in how they all get started, but not really an expert on. I know some, but that's mostly kind of what I'm aware of.
So, you've had so much experience over the last 20 years doing all the things that you did. But from just a pharmacist's perspective, what immediate policy changes or operational fixes do you think would reduce medication non-adherence due to cost?
Sure. Um, again, I think that more of the transparency business model, trying
Mm.
to get a more focused, predictable cost for the pharmacy so that they can keep it at a predictable amount, but make it reasonable for the patient on that side. And then if we can, a few different things I think could be helpful. If we're going to keep the current PBM system, we need to make a strong push to remove prior authorizations. And if nothing else, move to a, sort of feels more market like that everything should be on a formulary and it just be different tiers, because that's extremely a hindrance to patients. And it's a very cumbersome task for the physicians as well. It takes too much of their time. And I would also go one step further and have like a collaborative practice agreement with a provider on what they want to do, and make our own the ability to have the list of patients' formularies accessible from both sides, and kind of create agreement where, if it's, I don't know, let me think about it. Well, we just say what a brand X and there's a brand Y that are in the same therapeutic class and have good data between both of them. They're fairly comparable in the studies and whatnot. And if one is like a tier 3, or even if we still will stick with the PA, we have the ability to substitute it because the physician says, yeah, it makes sense. If we can't get this one, let's do this or whatever. And then just kind of eliminate some of those constraints, I think could be really helpful. And then again, just we got to remove the clawbacks. Even though when they're against the law, they're still doing it. That NADAC dispensing model is really good. And then I think one that would be super helpful would be on the service side. If we can't get the full service reimbursement from the pharmacy that we need, we could have a piece of that, but also have the ability to have an EMR, kind of like y'all do, where we can bill the HCPCS or HCPCS codes for some services that we could get paid from CMS, because I'm certain that we could show good outcomes to CMS and say this is worth the money. And then that again focuses it back to, let's leverage as much tech as we can to get the medications filled accurately and safely, but allow us to be out there, like seeing patients, helping them directly, and being able to generate revenue stream for that. The other option is just simply give us provider status so we can use CPT codes and do what we need to do. I think there's a perception out there from some physicians that they're trying to overstep our boundary and whatnot. Or I think that comes from a lot of the older school doctors who've been around a long time, and it makes some sense. It really does from that perspective. But a lot of the new doctors are just like, we want to help and we want to figure out like what we're good at and what we're not, and find these gaps. And all these gaps are the types of things we're talking about, like OTC meds, like antibiotics and birth control, and just several things that are kind of high demand needs that have too many gatekeepers and barriers between them. So I think that could be helpful. It'd be less costly because, again, we talked about how we have multiple revenue streams coming in and we can keep that service fee relatively low. And so that can save, and it gives them better access to some of that type of care. And then just simply build a referral stream.
I do agree. I do agree with you that there are certain situations where we've had care being delayed to patients, and oftentimes it's something as simple as, hey, what's the dosage that you want on this particular antibiotic, or what's the dosage that you want on this blood pressure medicine? And unfortunately, it takes time just to get a hold of me, or, and vice versa. And it just makes sense just to give pharmacists some degree of freedom, because you guys know the dosing, if not better than we do many times. And so I do agree with that. I do agree that there is a role that pharmacists can play and help expediting care, but also and this is something that I think a lot of people on the medical side would really agree with, reducing the burden on providers. Is there really a necessary need to have all these unnecessary safeguards at times for something as simple as the dosage on an antibiotic and the number of days, when you guys know just as well as what we do? And I do agree with that. You mentioned single-payer healthcare system, and that is something that I'm also really interested in advocating for, because I don't really think the system that we have right now is working. I think everybody can agree with that. And so you really have to think outside of the box and look at something like single-payer, because it does seem to be functioning better than what we have here, at least across other parts of the world. Do you think the United States is now more ready than before for single-payer healthcare system?
I wish I could say yes to that, but this country is so deeply divided on political lines and on one side. And then I'm afraid it will just turn into a political device that divides, which we weren't near as divided under the Obama administration, I would argue. And we already had significant issues with even income. I mean, you think about it, there's a couple of things. One, to my knowledge, we are the only country in the world that uses this system. So my question is, if it's so great, why is nobody else using it? One. Two is when Obama was president, at that time he had he had like all layers of governance. He was the president, and he had the Democrats in both sides, and they still could not get it done then. You know what I mean? So that doesn't give me a great hope for it. I would love to, and I think people need to keep fighting a good fight, because I think if it's explained better, people will understand. This does not mean quote unquote socialized medicine. It still means we should have independent practices. We should have multi-tier. I think Canada and Germany do a fantastic job with that. They have a baseline layer where we respect the human dignity of people, and they can have that available, but they have the private sector to kind of gap over those issues that, like there might have too long of a wait or whatnot. And so it's kind of, you can pay extra if you want to get it, but ultimately we still have a system to where everybody's going to have access to good quality healthcare. Could you slightly take it to a level with private? Possibly, and some people will afford that, but at the very least, everybody's going to get this level playing field that is pretty good quality healthcare. Something along those lines make a ton of sense to me. And I think it just gets so politicized and buzzwords come around, and then everybody gets scared.
And then, real quick, I know there's a lot of people that are listening to this, and maybe they're still pretty young. Any words of wisdom for anyone of our listeners that is wanting to get into pharmacy?
Yeah, I struggle with that question, to be honest with you, because some of my kids are considering pharmacy as well. And I'm not saying that I don't tell them to do it, but I have some reservation, to be honest with you. And it's just because there's so many restrictions within the system that allow us to not do what we're fully capable of doing. I mean, we went and got our doctorate, and if you work in a corporate chain, you're doing very little of what you were trained to do because of the constraints of the system. And I know that to be true a lot on the primary care side. I know many physicians who are just getting burned out because they're kind of in the same type of situation. And I really think one day there'll be in the near future that medical schools won't offer just family practice, that everybody will be specialized in. And sometimes that might make sense. I mean, I think that for the most part, PAs and nurse practitioners can do a lot of that, and then they can just refer them and get your physicians honed in on the great places. I don't think you should completely abolish it, but I wouldn't be surprised if that came one day because of that. So I love my job, and I like doing what I do, but there's a lot of, you have to find the right place. And it is good that pharmacy is very diversified, so there's lots of different opportunities. But a lot of those opportunities are not really a good quality of life for pharmacists because, again, they're just so overworked and understaffed, and they're not doing what they're intended to do.
Thank you.
My pleasure. I really enjoyed it, and looking forward to being back. Thank you.
If you found this conversation valuable, share it with someone who could use it. And if you're on Apple, we'd love to hear your favorite takeaway and a review. See you next week.